Now, to introduce this amazing lineup, today we're going to talk about clinical trials, radiation. We're going to talk about so many great topics, and so I'm tickled to introduce Jalen Garrett, who is a nurse practitioner with Johns Hopkins Sibley Memorial. Please wave. There you go. Rashida, also a nurse practitioner with Rashida Persinger Associates. Jillian Thompson, nurse practitioner with MedStar Georgetown University Hospital, and of course, friend of our community and lung cancer survivor, the amazing Elizabeth Spate, who is a retired registered nurse anesthetist. So at this time, I am going to turn the session over to our amazing panel to get started. Thank you all for being here today.
Are you wanting us to introduce?
Rita, sure. So if you would like to go ahead, maybe. I think we've had some discussion in our community frequently about clinical trials, what they are, why they're important, and how the clinical trials bring us the medications, the amazing drugs that we have on market and available today. Would you like to speak to that about clinical trials, what they are, the enrollment, and all the things, please, to kick off our discussion?
Yeah, no problem. I actually will defer to Jillian, if you don't mind. She's at Georgetown, that is probably more active than what I am currently in that clinical trial setting. Maybe you can answer that question.
I can. Can you all hear me? Okay. Louder. Okay. So yes, I work at Georgetown University Hospital Lombardi Cancer Center, and we actively have many clinical trials available for lung cancer patients. They are available. So one of the good things you want to always consider when you're talking with your provider are what options there are outside of the standard of care. Clinicaltrial.gov is the best place to go, and you can go in and type in your diagnosis. What it will do is it will show you the active clinical trials, and actually some that are not enrolling, but then those that are, it'll tell you exactly the location where. So if there is a center near you, then it will show that they're actively recruiting. It usually has the contact number. And if you need assistance, just speaking to your provider, they can assist you with that, of getting in contact to determine if it's an appropriate trial for you. Clinical trial drugs give you access to medications that you wouldn't be able to get otherwise. And we've found quite a bit success in that. I've worked in oncology for quite some time, and now that we have targeted therapies, ADCs, we have a lot of access to medications that are doing amazing things and are being fast-tracked to approval. So it really gives you an expanded access to treatments. And collectively with your provider, whether the clinical trial is at where you're getting your care or if it's somewhere else, we work together to make sure if it's an appropriate treatment, we can get you involved in that.
I would also add, I think you came up in one of the other breakouts on yesterday. Can you hear me? No? Huh. My mic's on. It says, okay. I'll just keep on talking, okay? In one of the breakout sessions yesterday, there was mention, and I completely agree with it, is, like organizations such as Longevity or those patient-centered groups that are on the site where you're communicating with others, and maybe someone knows from a different part of the country that there's something that's coming down the pipeline, and so therefore it keeps you kind of abreast where you can go back and speak to your provider to see if they have any insight on that particular clinical trial. So I think, yes, I agree with you, Jillian, but I also think that we cannot negate the importance of groups like this and different organizations that also provide information to patients and their caregivers.
I think
I don't know. Am I heard? I think I'd like to also add from the patient perspective. I'm trying. I'm screaming. From the patient's perspective, when I travel places, I've heard people in the audience ask about family members or themselves. Should I get involved in a clinical trial? Is it safe? What should I expect, and how expensive is it going to be? Are they going to treat me like a rat? You know, what is my life going to be in a clinical trial? And from a medical viewpoint, having worked in medical care for 45 years and nearly 40 of that, looking at people's lungs every single day in anesthesia and caring for the frail patient, I get it. And so as a lung cancer patient, I was told I had 100 days to live, and that's not good. And so I did jump into against the advice of my oncologist, because he didn't think it had been tried yet or tested. He was wonderful. He got my diagnosis with a comprehensive biomarker panel, which identified the RET mutation, but there was no therapeutic treatment for it. So when you have no option, everybody in this room wants to live as much as I did. And I thought, what did I have to lose? And if I couldn't do it for myself, perhaps I could do it for someone in the future. I truly felt that, but more that I wanted to live. And so we jumped into this phase 1 drug trial right up front, and they treated me, so that you can understand, with the utmost respect and professionalism. Not all drug trials will provide care for travel, and reimbursements. But this one paid for my airfare, and this one paid for my hotel. They gave me a debit card for meals and taxi. I didn't want for anything. My car payment, what I had left over on the debit card, paid for my parking at the airport. They treated me like royalty when we checked in. I spent 12-hour days right up front just for a picture of what it felt like. They hooked me up to EKGs and labs. I had to have lab work drawn every 15 minutes and then 30 minutes, a set pattern and sequencing over 12 hours. And at the end of the day, my husband and I went back to the hotel that they put us up in, and he had his own lounge chair. They offered food, not just crackers, sandwiches, salads, whatever. So they treated me very kindly. And I want people to know that not all are the same. I'm sorry, can you hear me better now? Not all drug trials are equal because they're different people. But you can ask, perhaps, what do you cover? And even if they don't cover, I was willing to pay for whatever it took. I don't want them to know that, but I wanted to live. And I want to share with you not to be fearful, because you've got to remember, they want to succeed in what they're doing also. They were my best keepers for 4.5, nearly 5 years. They wanted me to be successful. I could make a phone call away, an email away, no problem. They were there 24/7. And as a matter of fact, when the trial came to an end and it was being put on the market, I felt like a little bird getting kicked out of the nest. I wasn't sure I could do it by myself. But I can. It's almost 8 years later. I just want to share that about drug trials.
We have a lot of questions popping up in the app here. One of the things that has gotten a lot of votes, so a lot of people in the room want to know, are what are some tips that would help me advocate better for myself during my appointment?
Okay.
I think that's probably something that all 4 of you could answer.
Yeah.
I guess I'll start. You know, I'm always an advocate to making sure that you remember that we're making patients aware that they are their best advocate. And so in order to do that, I think you have to understand that you may go against the grain at times with your questions, but it is your life. You're, as she said, you're trying to live as long as you can. And so I think one is to, if you can have somebody to come with you to your appointments, that'd be great, because you're trying to listen to everything that's being told to you. Maybe the other person can remind you of the questions that you all discussed about before you got there, and maybe taking notes. And so I always think that there's a good kind of plan to do that as well. I used to work at Hopkins with Jalen, as well as I used to work at Georgetown also. And I know that when we go in there, sometimes we can get so like, oh, they know it all. And they are the experts. They are the oncologists in their particular field. But I also think that you have to feel empowered to come with your questions, even if it seems small to you, even if you may think they answered this last time. You need to walk away and be able to recite to yourself what took place in that meeting. You know, and sometimes that means repeating yourself, that means asking questions, that means maybe somebody else. If you're not the person that can speak up all the time, maybe that person that goes with you is that person who advocates for you.
I would agree with that. You know, I work in radiation, so I work with a myriad of patients, but I always tell my patients, if you leave here more confused or not have an understanding than when you came in, I didn't do my job. And for this reason, I make sure I spend my time with my patients. My patients all know that I may run over or something, but I'm giving everyone the appropriate time to talk, whatever that means. Sometimes it may not be directly about just your health. It could be something else that opens another door that is the reason why you're feeling certain ways. But I do make sure my patients are advocates as far as like, this is, you know, if you heard Michelle's story yesterday with her trying to get a lumbar puncture, like this is your health. You know, you can only do, you know, only oncologists or NPs, whatever, can do so much. Like, you have to speak up for yourself as well. And I make sure patients understand, like, this is your diagnosis, this is what you have, this is what questions you need to ask. You know, if I can't answer them, I'm gonna help you get through to the next person. So speaking up for yourself is the best thing. And like Rashida said, you know, if it's not you, bring someone who can. It's okay. Like, we're not gonna be offended by it. Like, I need to make sure that you understand what you have, what you're going through, and how can I get you to the next step.
And I will echo what they've said. I always tell my patients, you tell me how to take care of you. So it's very important that we have that open dialogue. So there's never anything that's too small to discuss, because that may ultimately be the thing that determines if we make adjustments in what we're doing, if we can offer something additional to make the whole process easier for you. We're partners in your healthcare. We want to see you succeed and do your best. We want you to get through your treatments well. So really coming in there knowing that we're doing a service to you and letting us know what we can do to help. And I think that we have had so many advancements just on the medical side that allows us to have options, but I think the most important thing to think is partnership. We are working together, so in that partnership, speaking, saying what you have to say, like I said, I totally agree with bringing someone else in to be that second ear. There's a lot that you're going to hear. We try to repeat ourselves, and I'll tell people we'll sound like we're repeating ourselves, but that's because we know that there is a filter through that. You're dealing with a significant change in life, so you may be thinking about other things in addition to just the treatment, your cancer itself. So having that advocate, speaking for yourself, figuring out, do I need to, in some cases nowadays I have patients that say, can I record our visit? Mm-hmm. That's perfectly fine, because then some people come in and they don't have family that comes with them, and they ask them questions, which then becomes pressure for them to try and answer those questions. If your provider is fine with the recording, you can just play it for them. Sometimes I have patients that say, can I call my family on the phone so they can listen in on the speaker? If they have questions, they can ask questions directly. I think most providers are going to be okay with that approach. If they're not, there's other things, taking notes, having a journal. I tell patients, when you're at home, Write things down before you come in because it's so easy to forget. You're overwhelmed, there's a lot going on. So those would be my suggestions on being your best advocate.
I'm going to jump in where you just said that, Jillian. That's absolutely perfect. All of us know that when you first get your diagnosis and you may be getting radiation to the brain or chemo, that you are not up to snuff. And I knew all this stuff when I was going in. I could hear the physician speaking to me. I completely comprehended it, but 10 minutes down the road, I couldn't remember hardly any of it. Having your advocate, whoever it is, if it's your spouse, a partner, a family, a sibling, someone there at all times is critical. When my husband couldn't make it because he had to go to work, I'd look right at my oncologist and I say, oh, okay, I'm calling Kevin now, and we'd put him on speaker. And clearly, a year and a half later, when the fog started to lift out of all the heavy chemo, you know, all that toxic stuff, I started to be able to think a little clearer, but I thought I was on snuff. I thought I was up to par, and my husband would be sitting there, well, not sitting there, on the phone, listening to me speak to my oncologist, and he'd say, Liz, do you have this, this, and this, and you know, no, nothing's going on. What's the lung cancer patient traditionally say? Knee-jerk response when somebody asks you how you doing? I'm okay. No, there's a lot more to it, but that's our response. And I responded to my oncologist, no, not much going on. And my husband's going, that's not true. Remember, you had this, this, and this. So you get called on those things that you're not thinking about. And quite honestly, I'd forgotten it. Even though it was gut-wrenching, nausea, vomiting, and pain, I'd forgotten that because that's just part of the deal, right? You just live life and you move on to the next thing when you're in it, when you're deep into it initially. So particularly initially, someone should be present. And afterwards, if you're capable of driving yourself and going to do those things, have somebody at least on the phone. And if you can't do it, record it, because they're recording you. They all come in now and they're recording so they can give it to their smart technology, and it's okay. They don't care. My doc's always, no problem. You can do that. It's not an issue because it's about you, and you need to have clear communication. And the other thing I saw, there was a couple questions I'd like to talk about. How do you advocate for yourself best? That's how you do. You keep your data, and then you know it. You can go back and review it later if you need to. And you can talk with somebody. Make your notes, write it all down before you go. Somebody asks in a question box, I go for 40 minutes, and I know they block you 15, 30 minutes, 40 minutes. The oncologist knows when he comes in, he says, I blocked extra time because you and Kevin are here today. We know you can have that time. They're extremely busy. They're running us. I grew up on a beef and dairy farm, so the farm is running us like cattle through chutes. There's a patient business in hospitals, and they're very busy, but they have the time to hear your questions. Promise me. I promise you that.
Is it fair to use your nurse to influence your doctor?
I won't say not fair. We become part of your advocacy. So in my realm, it's, you know, I do have a good relationship with my provider. So if that comes the case, it's not that it's not fair. It's we can be an advocate for you in that sense. So I don't think it's not being fair. It's just using the tools that you have to help kind of get through there. You know, if it's not, they're not comfortable talking to the provider about it or something, like, that's okay. I can be a listening ear and kind of give those decisions, like, this is what we discussed, and what do you think about this? So it's a different approach, and since we have that relationship, most of us, at least with our provider or someone you're working with, it's not an unfair thing, especially if you're not comfortable doing it. Then you're speaking to me, I now become your advocate, and that's okay.
And I would, when I was in full-time clinic, Dr. Levy and I, we always refer to each other as that's my work husband, I'm his work wife. And so I also lean back on what Jillian said in terms of that partnership. So I don't see it as well as it being, is it fair or not? It's a partnership. And anytime when you have a partnership, there may be one person you can lean on a little bit more on a certain subject versus the other. And I think that's the benefit of having that team approach and having different members of your oncology team, because maybe just like Jalen said, now I'm getting tongue-tied and I know you all, just like Jalen said, I can, you may speak with me about something that I can feel a little bit more, have more access to the physician partner, and so therefore that they can understand the need, and so therefore it can be addressed. I think at the end of the day, I'll say this forever and ever, it really doesn't matter if it's fair or not. It's your life, and if a point needs to get across, it needs to get across however, whatever resource you use, it needs to get across.
All right, and next, there's a question about how do you manage symptom side effects? You girls give them some great advice, I know that.
Well, there are a number of side effects associated with the treatments that we give. And I think the first part of that is speaking to your provider. And that's why I say, again, you tell us how to take care of you. Typically, when you start a treatment, we're going to kind of have some things set up initially to tell you what to do, like for nausea, for energy, things like that. But things change. And maybe what we plan initially is not as effective. Letting us know that and not just saying, well, they gave it to me, it's not working, I'm just gonna go with it. Tell us it's not, because then there may be other options. And I think also we have other resources outside of ourselves. So if there's some side effects that you're experiencing that maybe there's another provider that can offer something we can't, then we can refer you there. We have oncology rehab, where we have someone that specializes in a lot of the side effects related to cancer treatments, whether it's active treatment or after. And so when patients tell us that we have a referral, we can send you directly there and they can help you with that. But really it's speaking up and saying, this is what I'm experiencing. We can give you advice on how to take your medicines. We can verify, are you taking them correctly? Are you taking them at the right times? Communication is such a core piece of the relationship. It is a relationship, it is a partnership. So think about your providers in that way. And everyone says communication is the key to a good relationship. So I would do that.
Yeah, from radiation, I would agree. When we see patients up front, we give patients, sometimes it's like called the radiation Bible, just a list of things from skincare, what to expect during treatment. We see patients once a week when they're getting radiation. And I always stress the patient, this is the time, write things down. Yes, you're here every day, but when you go home, you can forget things. I experienced this on the weekend, let us know. Whether that's through my chart, email, in person, we're there for you. So don't let it, you said I can experience this, but what's too much? I need to know. I can tell you, no, this is expected versus not expected. And, I see patients in the clinic, what I call emergency visits. So if there's something going on, you don't have to wait till your on-treatment visit. Let us know now so we can address things, no matter how small you think it is, whether that's during radiation or, of course, well after treatment's over with. That's something that you need to always communicate and let us know, because I won't know how to address it if I don't know how long it's been going on, or this has been 2 weeks versus 2 months. Let me know. It's fine. You can, no matter how small you think it is, always let us know.
And I would echo what you all say, but I would also add that we also take ownership as well. I think in our visits, I've always used to be told, Rashida, you're taking so long, because I go through head to toe, because I know in going through those review of symptoms that it may trigger something that you have maybe forgot to write down, or maybe send a message ahead of time. So we also take the ownership, as well as it is a communication, a partnership on both sides. And so from my standpoint, I like to do that head to toe, just to make sure that we level the field to see if there's anything that may trigger your mind. And I agree too. When patients come in, typically used to see me for what we called a chemotherapy or biotherapy teach class. And in that teaching class, we go over everything that is possible that you can go individualized, not in a group setting, individualized, going over it. You have a medical oncology Bible, I'll call it, in terms of things that could happen based on your treatment, and included in that are numbers, how to get in touch with us, and so forth. And so I would add to that that it's also an ownership that we have to do in making sure that we ask questions to see if that may trigger any additional information you can give us.
And if I can also respond from the patient perspective, I think this question is so important. It's all about symptoms, fatigue. I'm reading in the questionnaires. We all just want to have a normal life and get up in the morning without being exhausted. I'm sure that several of you, if not most of you, when you began your treatments had extreme fatigue. I mean, I could get up and go shower, run back to the bed, lay down, get up, dry my hair, lay down, get up, get dressed, and then go lay down. It didn't matter. But over time, things do get better, but they don't resolve. I think planning in the morning to when you get your best energy, and morning doesn't have to start until you tell it to. If you're not working, sadly, a lot of people are still working. Our younger lung cancer people are still having to work to provide for families. But if you have that ability to sleep in an hour extra, go ahead and do it. But then try to get everything done by noon if you can, when you know you're going to start to wear down. Or plan your day when you know you're going to do something with that in mind. Get things done earlier in the morning. And also, being on certain drugs, I had a particular drug that I take that actually started to exhaust my thyroid. My thyroid quit functioning. So I would recommend you all, if your physicians have not done it, get a complete thyroid panel, you know, T3, T4, TSH. Make sure that you're all doing well in that respect, because I'm taking a medication for that, and the fatigue has gotten better, not resolved, but better. And then the other thing that Jillian was saying about medications, several drugs will interfere. So if you are taking things differently, all at one big thing in the morning, then you might revisit that, how you're doing it, because I actually had a drug that couldn't be taken 4 hours before my targeted therapy, and another one had to be taken with no food, and then one drug's taken twice a day. I literally set my alarm on my cell phone 5 times a day for several years. I'm down to 4 now. So, in
And
that
Elizabeth,
respect.
are there specific questions in there as it relates to symptoms that they were asking about?
They were asking about fatigue,
Okay.
and they were asking about, let me pull it up again, about medications and the symptom management.
Okay.
And you guys
pneumoni-
addressed that.
Okay.
Let
And
me get to another
pneumonitis.
one for
There's a
you.
question about pneumonitis as well. So
Say that again?
pneumonitis.
Pneumonitis.
Yes,
Okay.
pneumonitis, thank you.
And is the question about how to manage it or how to pick it up? What was the,
What are the symptoms
what's the symptom?
and treatments, and how do you, and does it sometimes, where it just moved, mean your cancer treatment, targeted therapy will be stopped if you get a pneumonitis?
Okay.
There's also a question on chemo brain or cancer-related cognitive impairment as well.
Okay. So I'll take some of the pneumonitis, and maybe Jillian, because I know you can speak to it as well. Pneumonitis, just think of it as inflammation in the lungs, right? So, and certain drugs can cause this: chemotherapy, immunotherapy, as well as targeted therapy. And so it's just inflammation in the lungs. In terms of will your treatment stop? Because we hear this, right? Patients are hesitant to report their symptoms or answer the questions that were asked and fear that their treatment will be stopped. And what I always would say is that we need to know, because it may not be that the treatment needs to be stopped. Maybe we monitor you closely. Maybe we do have to pause it for a moment and maybe revisit restarting it. But what we don't want to do is that what we know with pneumonitis, untreated, can lead to death. And so we need to have that conversation. Are you having a cough that you can't explain? Did you notice all of a sudden when you went to the bathroom that it never really bothered you, and all of a sudden you feel a little shortness of breath? Or maybe you're in the clinic and your oxygen sats that they're checking, you used to be 99%, and just strangely it went down to 91%, but you don't even have any of those symptoms. Those are things that your team are, honing in on to see, is there signs for something going on? And obviously when you get your CT scans, the radiologist may comment on something that looks a little suspicious, and those are the symptoms. So I'll go to you with the treatments, Jillian, if you want to take care of that.
So kind of jumping on what she said, sometimes the treatment is pausing your treatment. In many cases, we will give steroids. And there's no rhyme or reason to that, but we usually, we'll dose it and we'll slowly try to taper you off of it. There are cases where patients don't exhibit, like you ask them, they're like, no, I'm not particularly feeling short of breath, but you notice something like their oxygen. So we may, hook you up to the machine, walk you around the clinic, things like that. But it is so important to just share those things. And I have this thing that I tell patients, do not take in that no pain, no gain when you're considering your treatment. It doesn't have to be horrible for it to work. I always tell patients, if we're giving good care, we're able to get the benefit of the treatment as well as make the side effects manageable. We can't get rid of everything, but we can manage some things. Pneumonitis is something that we don't want to get out of hand because we don't identify it early, because it could get to the point where we can't give the medication. So when we're communicating, if it's just a little bit, I have a little more cough than normal, I'm a little more short of breath when I'm doing activities, that's going to be helpful for us to kind of look into and determine, do we need to make some adjustments to what we're doing?
And here's a question that goes along with that. During the patient's care with their oncologist, would the team be upset with them if they asked for a second opinion?
Not at all.
Not at all. But I mean, I'm a little rodeo. I'm like, who cares if they do get upset? I mean, at the end of the day, it's your life, so you have to excuse me. That's just my approach. It's your life. It's not my life. It's your life, and you're trying to get that best information for your care as you go through this journey. But I wanted to go back to pneumonitis because I forgot about my great partner here. In terms, I said biotherapy, chemotherapy, and target therapy, but we can't forget about radiation pneumonitis that also can muddy the whole field on, is it coming from the oncology side or is it coming from the radiation side? So I just wanted to see if you wanted to speak.
Yeah, so with
to
radiation, obviously getting chest wall radiation, something that's going to be close to the lining, you can have a risk of also getting radiation pneumonitis, which can occur sometimes acutely the first couple of weeks, sometimes it can be a little bit later. So in the same realm, we're stressing if you have a cough that's more than your significant cough, obviously, or this is different, or shortness of breath, we need to know about it. I know with lung cancer, like you said, muddy the waters, if it's just me coughing or is it my chemo or things like that, we just need to know, because we can get a simple chest x-ray. Let's just start with that. That takes nothing to walk down, get it immediately. Let's just see what's going on. So I'd rather be erring on the side of caution than just leaving it to, oh, it's just from this or that. So, and the same with radiation. We do talk in detail about radiation pneumonitis because it is a risk, and that we would address it the same way with steroids or typically or things like that. But just letting us know up front is the best key.
And there are, one more thing if I can say, there are other treatments besides steroids that can be used. I know there was a lot of, in terms of, and I'm going blank on the second line therapy. Can somebody help me here?
Yeah, I am too, but
it's the intravenous one. It's IVIG?
IVIG, did infliximab?
Yes,
Yeah, infliximab.
Yes.
And those are usually if the steroids don't work. But I think, again, typically, if we can kind of catch it earlier,
Yeah.
steroids will work, and in some cases, it doesn't have to be a long course.
Yeah.
All right, great answers. I have a question. What is the best test for a Acinar cell type since it forms in layers, not solid tumors?
Can you repeat that one more time?
Acinar, A-C-I-N-E-R, cell types.
So that's a particular histology, different histology. And in all fairness, I don't want to speak to it incorrectly to provide you with all the details. I had that question come to me on Friday, and I'm still pulling information for that person. So if it is the same person, I have not forgot about you. I promise you I will send it out. In terms of the histology may be a little different. The treatment course may be slightly different, but it's still going to include that chemotherapy. I'm not even for sure if immunotherapy is usually treated. But I know chemotherapy, and I know there's no biomarkers that are for that particular histology type. Do you, Jillian? Can you
I don't believe there are, and again, I don't want to speak incorrectly to that. The question, a lot of it does have to do with the histology, which I have a general understanding with, and kind of our pathologists are who we kind of refer to with that. But as well, we can, if it is a different person or not, it's someone we can definitely follow up with.
Yeah.
Going back to pneumonitis, someone asked, can it be mistaken for something else in the ER?
Infection.
What's the infection?
I don't know if anybody was here on Friday. Dr. Andrew Lerner was here. He's an interventional pulmonologist. He's amazing. And he taught me how to, like, when you have a patient and they're coming in and they have symptoms that mimic both pneumonitis as well as, could this be just pneumonia? He always says, he starts with antibiotics because typically antibiotics should improve things within 24 to 48 hours. You should see some improvement. And if it does not improve, there is even a more high suspicion that it could be pneumonitis, because on the scans, on a CT scan of the chest, they look very similar in terms of is it inflammatory from the pneumonitis or if it's inflammatory from infiltrates from pneumonia. I don't know if any of you all have anything else to add to that.
Yeah, I mean, that is essentially true.
Yeah.
And I have a question, the next one. How does my care differ if you are in a study? I've heard the term phase used in studies. What is a phase?
Phase or phase?
Phase.
Like
Okay.
Okay. So the first part, how is it different?
Would their care be influenced in any way? Would it be any different?
So you spoke to it. With clinical trials, there is a lot of more pieces that go to it, and you will get a lot of more individual attention in that there are very specific guidelines with clinical trials. So your schedule is typically going to be more involved. You may spend more time at the infusion center or seeing your providers due to what is required of the clinical trials. And again, every clinical trial is different. So that's it. A lot of times when you look at doing a clinical trial, it is a time commitment. It gives you the access to drugs that you wouldn't have access to otherwise, but it is a time commitment that you are giving to the providers, the people running the trial, because they're gathering quite a bit of different information. Like phase 1 trials, when you're looking at those, particularly these are trials that they've had like animal models. They're essentially in that stage trying to determine what is a safe dose. And so they may have different dose levels that they're testing out to determine what is the most effective and what can be tolerated. There's some of that too. When you go into phase 2, phase 3, essentially what you're looking at is they're gathering different types of information, and the information that they know about the specific drug can vary. Also, they can start to use, like there may be a drug that's already approved and they're combining it with a new drug that has yet to be approved. So there is a lot of involvement. And again, when we have patients who are coming in for clinical trials, we really do take the time. You're usually going to get a informed consent that can be thick. It can several pages. We're always giving you that information and giving you plenty of time to read through it so that you can ask questions, and that's very important that you want to take that time. If anyone ever just gives you a informed consent and looks for you to sign it immediately, that's not how it should happen. At minimum, you should have 24 hours to read over that information, come back, ask and have your questions answered. The thing I also reinforce with patients with clinical trials, you sign a consent, but it is not written in stone. If at any point you decide, I don't want to do this anymore, you let your provider know. We do not take that personally. That is your right to get out of the trial. So there are a lot of hesitations when it comes to clinical trials because there is history of people feeling like I'm a lab rat. That is not what is happening, and you should not feel that way. If there's any concerns or questions, make sure that you're answering them. Usually you're going to have an assigned coordinator for that trial that you're typically going to be in communication with quite a bit. Our coordinators are really good, and usually that's who they will contact immediately, whether it's about scheduling. They usually will schedule scans for you that maybe typically you would have to do on your own. They will schedule all of your visits, and they can answer many of the questions because there are so many small little pieces of the clinical trial. They're also the ones that are usually going to communicate to you, are there some monetary support with that trial? They're usually the one that's going to arrange that and make sure that you understand how that goes. So your care is going to be a little more specialized because of how involved the clinical trials are.
Yeah, I would agree. From the radiation standpoint, we will have patients who are obviously getting chemotherapy or on the clinical trials that we need to make sure that we are also abreast of and things we can and can't do. So for us, we as well stay in contact with the clinical trial coordinator or research nurse to say, hey, is this okay for this to do? Or a patient has questions about this, they have this symptom, and sometimes the patient may not at that moment get a chance to ask, like, hey, we'll just pause real quick, let's ask. So we also are very much in communication with the research team, making sure that we are staying abreast of everything and what can or can't be done, or what we can also do to help the patient that is not going to be a problem as far as the trial itself. So.
And if I may, I can just let you know what a regular, I call it a collaboration between the drug trial physician and my own personal oncologist that I had at the hospital. When I got involved, we traveled to a different state, but I would always have all my lab work and my, when COVID came particularly, you couldn't travel. So I went to the local hospital and would have my lab work, my CTs, my MRIs, all that stuff done. And I would ask for another disc to send to them. You can look at all these things on the communications, the regular screens in their offices, but they had clear visions up there, and then they had their own personal physicians and oncology radiologists that would read these things with a fine-tooth comb. So I would just send them that through FedEx every time, even after COVID ended. But in that respect, they would look at materials at their end for their data and the research. I would still continue to see my oncologist at this end. And anything else, the side effects and all that, he would address immediately. If I had a problem or anything, I was right there immediately. I didn't bother with urgent care because they didn't know what to do with me. I would just call up the doctor's office or send my chart, something real quick. And I would also communicate with MGH up in Boston at the same time. let me get our next question. You guys are great. From a viewer at home, if they don't suspect pneumonitis and antibiotics are not working, how do you bring that up to ICU doctor who has an ego and is difficult?
It's a loaded question.
That's a very loaded question. You know, yeah, that's a difficult one. I think, again, it goes back to being that advocate. You know, if that individual is in the ICU, their conversation or their energy to go back and forth may be depleted. And so that's when it is essential to not only have that advocate from the family side, but hopefully that you have developed a great relationship with your oncology team, that now they can step up and speak to what they feel in their experience of whether or not this is or not. It's a little trickery situation to be in because that patient is in the ICU, and the ICU's point is we're trying to do whatever we need to do to stable so they can get out of ICU. And so it is hard. I don't know if there is an exact answer. I think it will all be dependent on the particular facility, the relationship that you have with your oncology team, your family advocates, because some of us have some family advocates that, you know, they even scare me, sorry.
Mm-hmm. Yeah.
So, you know, it's, you know, not to make a joke about it, but, you know, it really is very complex situation in that moment. And I don't know if there is a right answer that I can provide to speak to that. What about you all?
I mean, I agree. If you're having a good team, you know, relationship with your oncologist or just the team itself, you know, even though, yes, your ICU team is like in charge at that moment, because it's like, okay, they're the driver's seat, we're kind of passenger because we're just trying to get you out of the ICU, but it becomes, you know, you don't want anything to be missed. Like, you're here, you want to get it addressed, and your oncology team more than likely will be making rounds or at least checking on you. It's like, hey, I know they're thinking this, but could you possibly, when you're having your team meetings or suggestions, let's just try to rule out pneumonitis, or they had this, they've had that. It could be a possibility, and that's where they can also, it's a team effort. They're not just the ICU team. They're gonna be talking to the rest of the team. Exactly. So in that moment, it's like, hey, let's just do this for giggles. If it's negative, that's great, but let's rule it out. It's not gonna hurt, you're already in the hospital. So that is one, you know, thing that should be stressed. It's like, yes, your ICU team is there, or whoever the team would be, if it's GI, whatever it is, like, but you also have a team that's there to be talking to address every part of the situation, looking at you as a whole.
Good answer. Do you have something, Jillian?
There's not much to add to that. I echo what they say. Working in the DC area is very unique. We have a lot of patients that don't live in DC, right. So they may go to a hospital outside of DC. And so it's not unusual that we will have a case where the physician from that hospital will call to get our input. So I think it is actually very normal for providers that if it's not their area, if they're not comfortable, to reach out and say, this is what our plans are, this is what we're working on, we're not sure, can you give some input? And we're usually very open to doing that. And then I've also had some cases where they will just, you know, contact their own oncology team that's available there to kind of give input. But usually, I think if you make sure that they know, this is my oncology team, you can reach out to them. Because, you know, hopefully you have a good relationship with your primary oncology team, sending us some message just so that we know to be on alert that we may be hearing from someone so that we can follow up is helpful also.
And can I just add, that viewer that's out there, I would also make sure that the ICU team is aware that you're not just receiving chemotherapy. Because speaking to what Jillian said, if you are in a community hospital who may or may not see, they just hear lung cancer, you must be on chemotherapy, let's treat that way. You know, making them aware that you are on immunotherapy or you're on a targeted therapy that can muddy that that pneumonitis picture a little more, sometimes maybe they have not reached out to the primary team yet, or maybe they just see you came in acutely, and they're just trying to stabilize you. That is their goal, and that's what they have in mind. So just making sure, don't assume that they understand that you're a lung cancer patient and you're on other possible treatment modalities that could cause this pneumonitis, making sure that they understand exactly what you're on.
We have time for like one more question.
Okay, I've got one more question. I feel like I'm on a medical merry-go-round with so many specialists and 2 different active cancers. Sometimes I can't figure out who I should be steering my ship or who to call for what. Can you help this person figure out how to manage this?
I do get this question a lot for patients who are just getting radiation and getting chemo. Even then, that's still 2 people. Imagine having more providers involved. And it does get a little, I won't say tricky, like, okay, if we're doing radiation, okay, we are in the driver's seat now, but when we're swapping and you're getting chemo or this, like we're not out of the picture, we're just kind of put in the passenger seat. Someone else is driving at that time. But it's never a bad thing to just reach out. If you don't know, reach out to one of the people. We can then help you direct on who should be addressing the problem. But that's my go-to. It's like, it's okay to reach out to me, even if it's about a chemotherapy med or whatnot. Let me know, let me be the starting point, that's fine, and then I'll help to kind of get things figured out for you. So it's not like you feel like you're burdened with it or who do I reach out to. It's okay to start with one place, and we can help address, by talking to your team. It's coordination.
And I would say also, I'm going to make some assumptions here that when you say 2 separate cancers, that it's lung and something else, and maybe not just lung and spread to like the brain or something. That is, I can only imagine how you feel, because if you're seeing a lung specialist, obviously that's their specialty, versus if you have a lung cancer and a separate breast cancer primary. I would agree with what Jalen said. I think it also speaks to the importance of when you're wherever you're getting your care at, identifying who is your go-to person, okay? Whether that is, obviously the physician is always gonna be there, but maybe it's the nurse practitioner, maybe it's the nurse navigator, maybe it's the infusion nurse, or maybe it's the clinical nurse. Who is your go-to person that has a record that when you go to them, they at least, like Jalen is saying, are able to coordinate whoever else needs to be involved. And it may even be your social worker. At Hopkins, there was some great social workers that also played a role in getting that information disseminated to all the team members. But it is a lot. I'm not going to make it sound like it's not a lot. That is a lot to have 2 separate cancers and how to manage that. But I would agree as well and strongly encourage you to identify somebody that can be your go-to, that can help you through this process so you won't have to own that burden alone.
And the last thing I'll add to that from the patient perspective, I'm certain absolutely all of you in here, it became my job. Cancer became my job. Even though I didn't want it to be, it's an everyday 24/7 thing to manage. And you can manage your scheduling. I travel an hour to get to the hospital, and if they wanted to give me a 7:30 lab appointment, I'm going, can we bump that up? I can't even get out of bed by then, and I have to drive an hour. And I managed to get all of my labs, my scans, my MRIs, my CTs, my labs, my physician's appointments, everything on the same day. Because it may be 5 or 6 hours, but you're pretty much there anyway every time you walk in. What's an extra hour? And they understand that. They will work with you with that if you speak with the scheduler, and the doctor will send your orders for your CTs and your MRIs to be done, but you have a say-so for the time and the day. You can get them all done on the same time and same day, and make your life a little bit more manageable so you don't feel like you're spinning your wheels all the time and always having to be there. And I do that because I've spoken with them, being a patient advocate, because I said, you have people who are elderly with other ailments driving their sick, elderly cancer patient in here every day, and they're not capable of doing that. over and over and over. So that's my only added point. Thank you.
This has been an incredible conversation, such good information shared. And to add to what Rashida said, find your people, find your community, find your team. You don't have to walk this path alone, whether it's a navigator, a social worker, your oncology nurse. Our community is here for you. Sadly, friends, we are out of time for this session. We are blessed by such amazing nurse colleagues and longevity champions, Jalen, Jillian, Rashida, and Elizabeth. Let's give them a round of applause.